Hi, I'm Dr. Brock Norrie. I'm new to the Bone and Joint Center. I just finished my fellowship last year in New York in hand, elbow, and shoulder. Just started in September at the Bone and Joint Center. I'm originally from Kenmare, so I'm a honker by definition. So did my Lansford there. What was your mascot? Cubs, yeah. Went to UND for my undergraduate in medical school. Went to orthopedic residency in Grand Rapids, Michigan, and then did a fellowship in upper extremity last year in New York. So happy to be back here. Happy to be taking care of North Dakotans again. So we're going to switch gears a little bit. I'm going to talk about shoulder, specifically frozen shoulder adhesive capsulitis. We're going to talk. This is kind of the outline of the talk here. So adhesive capsulitis, the itis, just like anything, is really an inflammatory condition. There's a lot of other itises out there. Plantar fasciitis, I don't know if it's really an inflammatory type of condition, as well as lateral epicondylitis is more of an osis. But adhesive capsulitis is more of an inflammatory type condition. So it's really a chronic inflammatory condition that leads to a capsular contracture of the shoulder. And there's 3 phases of that, which we'll talk about. The first phase is really the painful phase of it, and then later it starts to develop into some scarring and some fibrosis, and that's where you get your loss of motion. So a lot of patients will know this as frozen shoulder, especially a diabetic patient. They may even tell you they've had a history of frozen shoulder before. Epidemiology, I think this is on the rise as we see diabetes numbers kind of increasing, but 2 to 3% of the population is kind of what is quoted. I think that in upper extremity practice, I see a fair amount more of this just because either good referrals from you guys or this is what I do. So I see a lot of it. It's kind of underdiagnosed, but there's good prognosis for it. Middle-aged females is kind of the number or the predilection that you'll see for these patients, and there's no genetic or racial predilection for adhesive capsulitis. A lot of risk factors out there. We don't have a good understanding of what causes it, but there's a lot of risk factors for it, such as prolonged immobilization. So they may have had a fall onto the shoulder, nothing's broken, the rotator cuff is fine, but they get immobilized or put in a sling by their primary care physician, and they come in 6 to 7 weeks later with a frozen shoulder. Systemic issues that can cause frozen shoulder. Diabetes is probably the number 1, as long as thyroid, cardiovascular disease, Parkinson's, and tuberculosis. If you have diabetes, there's about a 10% risk of developing frozen shoulder. If you're on insulin-dependent diabetic, that's up to 40%. So very high. Diabetics usually will get it in one shoulder or both, so usually not at the same time, but it can happen. Again, age we talked about. And again, if they've had a previous history of it before, they're more predisposed to it again. Pathophysiology is very poorly understood. We know it's a chronic inflammatory type condition. We've actually done biopsies of the tissue taken from shoulders that had to go to surgery, and it does show inflammatory type cells, and then this progression to these myofibroblasts, which is kind of interesting. So myo is muscle, which leads to the progressive capsular contraction. This is very similar to a disease process called Dupuytren's contracture that we see a lot in the hand. So the tissue is very similar. There's actually phase 2 clinical trials out right now on Xiaflex, which is a bacteria that we use to break up the scar tissue in Dupuytren's disease. They're starting to use this in the shoulders now to break up the scar tissue in the shoulder. So I think maybe in the next 5 to 10 years we may see this being a form of treatment plan in the future. So the name adhesive was described by an Iser in 1945. He really described it based on the obliteration of the axillary pouch there. So if you see on x-rays or a schematic here on the left, you have kind of the normal pouch, especially if you put contrast in the shoulder, you get a nice distension of that pouch. With adhesive capsulitis, the whole capsule basically infolds on itself and scars to itself, so you have obliteration of that. So you will not kind of see the normal contrast that you see on the left is basically obliterated in frozen shoulder. Other cuts on MRI, the one on the right, you may even see increased thickening of the rotator interval, which we'll talk about in the next couple slides. So the natural history, there's a good prognosis for frozen shoulder. It's usually a self-limited disease. If you do nothing for frozen shoulder, the natural history is it takes 2 years to resolve itself, but if you try and talk to a patient, see a patient back for 2 years in your office every couple months, it's not very much fun. So we try and speed that process up with therapy, injections, and other forms of treatment. There's really 3 phases: the freezing, frozen, and thawing. The first phase is really painful, and that's where the inflammation is setting up in the shoulder. The next phase is the pain starts to subside a little bit, but they're still stiff, and that's where most of the capsular contraction comes into the shoulder. As the pain subsides, then we can start to get motion back, and they start to thaw or get their motion back. The timeline's very patient-specific. Diabetics don't respond as well to treatment and have a more prolonged course, but you can see some averages there at the bottom. So again, first phase of the sad phase is the painful phase. Then they're frozen, and their pain is still pretty high at that point, and then slowly over time they get better, but it takes months and months to get better. The presentation, most patients don't describe an injury. They will tell you that they just kind of woke up with shoulder pain. It was gradual over the last couple of months. It's very vague. They can't really pinpoint it to any specific location of the shoulder. They will say that when they reach for stuff, it's painful kind of at the ends of motion. And they will have some night pain with this as well. In general, you have to have a loss of motion at all planes of the shoulder. If it's just one specific plane of motion, it's not really frozen shoulder, so you may be looking at other diagnoses. There's a lot of symptoms that point to other pathology out there, so these are some things just to kind of keep in mind that may point to another type of pathology for the shoulder. Differential diagnosis, one that kind of presents the same way that I want to make a point of today, is calcific tendonitis. Kind of presents the same way. They don't really do anything. It's kind of this insidious onset of shoulder pain, and the shoulder can be very irritable to any plane of motion, so it's kind of difficult to distinguish those, but calcific tendonitis usually has a shorter overall time of causing pain. So secondary adhesive capsulitis, the number one cause is idiopathic. We don't really know. Secondary is post-surgery, post-operative. A lot of times I'll get referrals for someone that's had breast cancer, or they've had a long cardiac surgery where their arm was positioned in a certain position, and then they had stiffness and soreness start after that. So that's kind of the thought behind secondary frozen shoulder. Physical examination is really loss of motion in all planes. Probably the most specific thing that I look for is that rotator interval gets contracted, so you really lose your external rotation at your side. That's probably the most sensitive test for frozen shoulder. They all lose interrotation up the back as well. And a lot of times, the books will tell you they don't have a lot of pinpoint tenderness on examination, but I find if you palpate the anterior capsule or the coracoacromial ligament right in that rotator interval area, they will have pain in that area. So that's one thing that I kind of look for in exam. So the rotator interval is basically the interval it's between the rotator cuff, it's between the supraspinatus and the subscap. Again, it's mostly capsular tissue in that interval, and this is probably the one area that gets contracted in frozen shoulder. The diagnosis is largely a clinical diagnosis. Sometimes you get a referral for an MRI. You can see that loss of the axillary pouch space, but a lot of times it's just clinical. X-rays are usually normal. Sometimes you can see a little bit of posterior head subluxation on X-rays, especially if the anterior capsule is tight. It kind of pushes the humeral head posteriorly, so sometimes that's a subtle sign that there's some frozen shoulder going on. So arthroscopically, it's been broken up into a couple of stages, and you can see on these pictures on the top left, there's just kind of this global red inflammation. It just kind of looks angry in the shoulder. The next phase is you get more of a synovial proliferation. So there's synovial fronds there that just look a little bit more irritated and angry. As it starts to subside on the bottom left, you see more of that brown hemosiderin deposits there as this starts to resolve. And then D is really hard to distinguish anything in the shoulder. The BT is the bicep tendon, but the whole shoulder is just so tight that even with the scope, you can barely make anything out. So treatment, we want to obviously control pain, because if we can't control pain, you guys can't do your job and get motion back. So that's kind of where we try NSAIDs or injections to help control the pain first. The inflammatory phase, we do offer cortisone injections during that phase to help control their pain so that we can get them going in a general physical therapy program. I always tell my patients that the #1 goal is to control the pain. Next is to get the motion back. We can't really start strengthening until we have all the motion back in the shoulder, because if you strengthen a stiff shoulder, you just get more stiffness or more pain, then you start to go backwards or backpedaling your treatment. So treatment options, if you do just observe these, the natural history is it's going to get better. A lot of patients don't want to wait, and it is painful and frustrating for them. So I always just tell them it's going to be a long couple-month process, maybe even up to a year, but they just have to know that and stick with it. Physical therapy is very helpful. Steroids I find is very helpful. NSAIDs are kind of plus or minus. There's no good literature to support NSAIDs, although it is an inflammatory type condition. We start getting into the surgical treatment options if they've failed everything. Usually we're looking at 6 months of conservative treatment before we decide to do anything operatively. So 90% improve with non-operative treatment. 10% of patients will not regain their full motion, especially diabetics. They may have frozen shoulder develop again in that same shoulder. So I always tell my diabetics that it's going to be a little bit longer process in you and take a little bit more work to get that motion back, and you may lose motion overall. So therapy, I always encourage gentle-free range of motion exercises, home program, and I usually see them back in about 2 months. If they're struggling with pain, I'll see them back sooner to try and help with the cortisone injection so that we can advance their therapy. So NSAIDs, there's very little support for out there in the literature. Steroids, they've tried oral steroids. There's a lot of side effects for oral steroids, so I'm a big fan of intra-articular steroid injections. I try to actually inject the anterior capsule to try and get that steroid exactly where it needs to be so we can decrease the inflammation and decrease those adhesions so we can get them moving. There's been discussion of capsular hydrodissections. I've learned about this out in New York. We had an ultrasonographer that would actually inject saline into the joint and basically almost blow up or distend the shoulder joint. Sounds kind of gruesome, but they had pretty good success with that. But I don't have any experience with that, and I don't know anybody around here that does that. Manipulation under anesthesia, we'll consider this if they're not making progress with therapy. So your notes that we get are very helpful so we can see if there's a progression of their therapy and see if they're getting anywhere. There are complications of this. I did have somebody in my training fracture a humerus during manipulation, so that's a bad outcome. It's hard to tell the patients that you could fracture their arm by manipulating it, but it does happen. So this isn't my go-to procedure for frozen shoulder. I like to do it more arthroscopically, where I'm testing the shoulder before they put the scope in the shoulder. I'm releasing certain parts of tissue in the shoulder, and then I'm retesting the shoulder motion to kind of make sure that I did an adequate release in certain spots. So most of the time you're releasing the rotator interval first, and then if they're more tight at fore elevation and internal rotation, you switch the scope around, looking from anterior to posterior, and then you're releasing more of the posterior capsule. So it's really specific on what you're releasing. So post-release, then they have to be in aggressive therapy to maintain what you got them in the operating room. So in the old days, they used to admit these patients and put them in 90-90 splinting overnight. That's a little aggressive. I don't think anybody does that nowadays, but we just get them set up with therapy with you guys the next day. Getting going on therapy is basically the key for this. Prevention, anytime I see any injury that they come in with a sling, or if they're wearing a sling for an elbow or a wrist fracture, I always try and get them out of that shoulder immobilizer and sling as fast as I can, because I'm always thinking about frozen shoulder and preventing it. So take-home points, frozen shoulder is basically a mechanical straight range of motion. You basically lose motion in all planes. The rotator interval is the basic part of the shoulder that gets contracted, that chronic inflammatory part, and leads to fibrosis. Clinical diagnosis is how it's made. And again, MRIs, we do see those from time to time. And diabetics are more resistant to treatment. That's it.
So Dr. Norrie, so is it better to start like gentle PT, like gentle exercises, as opposed to really super aggressive physical therapy for the frozen shoulder?
That's a very good question. It kind of depends on where you think they're at in their stages. So if they're in that painful stage, I really try and quiet that down with a cortisone injection, gentle physical therapy. They've actually done studies that if you're super aggressive with therapy, you can actually incite more inflammation and pain and then go backwards. So you could actually be causing more harm by being too aggressive with therapy.
Thank you.
Yep.